So I guess we might as well get started. My name is Dr. Purchase. What I wanted to do today was talk about the new ways that we're treating knee arthritis. And we're going to cover from soup to nuts. But to start off, I'm going to give some basic information and talk about the knee. And the anatomy of the knee is pretty straightforward, fortunately for me and you guys, right? It's pretty much a simple hinge joint, but it's where the femur or the thigh bone comes down and it meets the tibia or the leg bone, and then you've got this patella or the kneecap in between. The bottom part of the femur has got these rounded things called condyles. And it's as the flat-topped part of the tibia goes back and forth on those rounded condyles that you get that hinge-like movement that we all know and sort of take for granted, right? There's also these condyles that sort of separate the knee to three separate areas or compartments. There's the one on the inside called the medial compartment. There's one on the outside called the lateral compartment, and there's the kneecap compartment or the patellofemoral compartment. Now, you probably know that the knee has a meniscus, right? It has a meniscus on either side. It has no relevance to arthritis, so that's what we're going to talk about. Very important structure, but not relevant to today, right? What's more relevant is the cartilage. The cartilage is the soft tissue covering on both sides of the joint. So both the rounded area of the femur and the flat top part of the tibia has got this soft tissue cartilage stuff. What it is a bearing surface of the joint. It's soft tissue that's designed to absorb impact, to be the cushion for the underlying joint. And it's the smooth gliding surface. This stuff, when it rubs on itself, is very slippery. Now I'm going to show some x-rays later what this stuff looks like on an x-ray, but it's soft tissue. So it doesn't show up in the x-ray. It's a clear space between the bones. So the way I kind of think about it, it's like the tread on one's tires. And when you have an x-ray, and you got these big, beautiful, clear spaces between the bones, you got lots of tread on your tire. And when the opposite is when you've got an x-ray and there's bone-to-bone contact, you know the cartilage is gone. You got steel belts. All right, so arthritis. It's inflammation of the joint. It is the #1 cause of disability in the United States. There are more than 100 different kinds. But again, fortunately for me, by far the most common is osteoarthritis. The top 10 most common, osteoarthritis, right? Osteoarthritis is a degenerative problem. It's a wear and tear problem. It probably started decades before you even had symptoms. Maybe it was a little injury that you had, maybe a result of some sort of repetitive recreational exposure or occupational exposure, or maybe even a little bit of the way that you were made. This developed over time. The vast majority of patients get arthritis like this. You can see in the drawing that the entire knee is affected, right? There's a handful of patients that get knee arthritis like this, where only one side of the compartment is affected. Now, on some level, it's a moot point because they both hurt like ridiculous, right? But on another level, when it comes to treatment options, especially some of the surgical treatment options, this is a huge difference, and we'll talk about that. Now, this is an X-ray of somebody with arthritis, and you can see on your far right, I'm sorry, I have a laser pointer, that one side of the knee joint is not so bad, right? You've got this big, beautiful clear space. That's the cartilage. Now on the other side, steel belts. You got bone-to-bone contact. There's no cartilage left. This is a pretty ugly looking x-ray because you also have the bone spurs, and you also have a pretty obvious deformity, either a bow-legged deformity or these knock-knee deformities that you can get. Believe it or not, as bad as this x-ray looks, depending on some of the other facets about this patient's presentation, it might be a good candidate for something called a partial knee replacement, and we'll talk about that. So my goal today, having set up the basis for the talk, is to talk about advancements in treatment. But we have to sort of, again, lay a little bit more groundwork and talk about some of the basic treatment options. #1, activity modification. It is the easiest thing to do and the easiest thing to overdo, right? It works great if there's this one thing that you do that really bothers your knee and it's something you don't have to do or something you don't particularly love to do, you just don't do it, right? That's the easy part. But no one, especially me, is advocating for taking activity modification and becoming a couch potato. So we're going to talk about that. And then self-help, this is like braces and canes. Heat and ice can be very helpful. Over-the-counter medications, this is anywhere from Tylenol. Actually, if you have a normal liver and you don't drink alcohol to excess, Tylenol is the best pain reliever for arthritis pain. It also includes over-the-counter ibuprofen and other anti-inflammatories, right? Topical creams. There are some interesting topical creams out there. The old-fashioned Bengay that makes you stink, right? And then there's like capsaicin creams. That's the stuff that makes hot peppers hot. For some reason or other, you put it on your knee feels better. And then there's also some creams that actually have anti-inflammatories in them. Prescription medications. This is mostly anti-inflammatory medications. You can use prescription narcotics for knee arthritis, but it's not something you want to use sort of on a chronic basis. It's been shown actually to be somewhat detrimental over time. Now, injections. If you have knee arthritis, you think I'm talking about cortisone, right? And I am, and I use cortisone a lot, but we're going to talk about other options besides cortisone. And then when all of that fails, you have joint replacements. So we're going to talk about some of the treatment advances, and we're going to start with the simplest thing to do, and that's activity modification. So activity modification used to mean just doing less of the things that used to make it hurt. But that's starting to change. We're starting to look at exercise, not controlling exercise to avoid pain, but using exercise to treat pain. Not only will it improve your overall health status, right, and make your heart and lungs better, give you a better sense of well-being, and help you control weight, but it can actually decrease pain. There's been some really good studies lately. This is a meta-analysis that's coming out in this month's issue of Arthritis and Rheumatology, right? So it collected a bunch of other articles and looked at it and trying to find some trends. Can exercise actually make knee pain from arthritis feel better? And the answer is yes, but not just all kinds of exercise. For the maximum benefit, max pain relief, you want to focus on aerobic capacity, thigh strength or quadriceps muscle strength, and overall lower extremity performance. And you want to do these exercises 3 times a week. So what does that mean? It's walking on good surfaces with good shoes. It's using the elliptical. It's riding bikes. It's swimming. It can even mean tennis, right? As long as you sort of control the volume and intensity, any of these exercises are great. It can even mean resistance exercises, lifting weights in the gym. So it can mean lots of different things. And you probably get, this study doesn't show it, but the more varied activities that you include in your 3 times a week, you probably get more bang for your buck. All right, now injections. Like I said earlier, we're going to go beyond cortisone. And the first thing we're going to talk about is hyaluronic acid. Who's heard of hyaluronic acid? All right, so I bet you more people than that have heard of it, but it's usually referred to as something different, right? Because hyaluronic acid, I can't say that more than a couple times a day, right? So some people refer to it as the rooster comb stuff, or the gel, right? Because it is kind of like a gel, and it was originally isolated out of the comb of the rooster, all right? And it's also, we also use the brand names. So there's a bunch of them. There's like Orthovisc, Synvisc, Flexa, Suparts, right? But what it is a complex, like organic compound. And somebody realized that a normal knee has got a certain amount of this stuff, and it's long chains. And in an arthritic knee, you have less of it, and it's shorter chains. So the brain surgeon then said, well, wait a second, why don't we inject the knee with long chains and more of it, and see if it makes people feel better, right? It's pretty simple, and it actually works. With people with mild to moderate osteoarthritis, based on x-rays, it works very well. Now, so there are a bunch of different brands, right? To be honest with you, the brands all work. There's not a significant difference for most patients. In certain instances, given your allergy pattern or something like that, you may benefit from one over the other, but they're all pretty good. All right. The newest injectable is this stuff called Platelet-Rich Plasma, or PRP. And I'm sure there's some people who have heard about it, right? Yeah, right? Tennis elbow, right? The data on that is mixed. The data on knee arthritis, while early, is very hopeful. Right? So, but what it is you draw blood from the patient. So my little drawing there, that arm is connected to a person, and that person's got knee arthritis, right? So it's coming out of you. You take the blood, you spin it down, and you grab this stuff called platelet-rich plasma. And the platelets are these things that are floating around in your blood, and they've got all these molecular goodies in it that are supposed to stimulate growth. So you take that stuff out, and then you inject it, instead of in the shoulder, you inject it into the knee. And the data, like I said, is early, but it's very hopeful. So this is what, December of 2013, showing that, I know the print is kind of small, but when compared to hyaluronic acid and normal saline as a placebo control group, so this is a well-done study, that up to 6 months later, the people that had the PRP were still feeling lots of relief. That's 6 months of relief. So, unfortunately, sometimes our conservative treatment options fail, right? And when is it time to consider to have surgery? And honestly, it's pretty straightforward. It's when the symptoms that you're having and the functional deficit associated with that are so severe that you've lost the quality of life. And the doctor has tried all those conservative options and nothing's working. And then you have that hard conversation with the doctor about, well, what are my chances of getting good relief? What's the recovery like? All that stuff. And you decide, honestly, that it's best for you. The doctor doesn't tell you when it's time. You tell yourself when it's time. So once you can make that decision, the goal is pretty simple. We want to decrease pain, restore function, and return that quality of life that you've lost. So a total knee replacement is a pretty simple thing. It's got 3 components. It's got this metal component that goes on the femur, on the thigh bone. It's curved, right? Because that's the bone that is curved. It's got this flat metal tibial tray that goes on the top of the leg bone, and this polyethylene bearing in between. So the metal components, you cut bone, you cut the arthritic bone off. The metal replaces that cut bone. That polyethylene bearing is the stuff that replaces the cartilage that's been worn away. All right, so how do we make
meniscus?
What's that?
Is that the second one, not the meniscus?
So we don't.
The polyethylene
is not, the meniscus isn't relevant in the arthritic knee.
Okay.
So how do we make a total knee replacement better? And this is a really hard thing to do, because the fact of life is total knee replacements is one of the top 2 most successful surgeries amongst all fields of endeavor of surgery. It's either open heart surgery or it's total knee replacements. And it's great for me because I'm an orthopedic surgeon, right? I mean, it's reproducible with a low rate of complications, and people in university centers can teach young little pups how to go out in the world and do it, and get good reproducible results with low complication rates, right? It's pretty straightforward, right? But let's make it better. Continue to make it better. And there's 3 ways that you can do this. Make a better recovery, make it last longer, and make it feel more normal. And what do I mean? This is one of those dirty little secrets that you don't usually get told about until you're ready to get a total knee replacement. That a replaced knee doesn't feel like a normal knee. It hurts less and works better than the arthritic knee, but it doesn't make your knee 18 years old again. Right? It feels somewhat different in a subtle but very real way. Right? So one of the most challenging things that we're trying to do is to make knee replacements feel more normal. All right, let's take a simple look at each one of these, right? So a better recovery. The most important thing, and perhaps one of the biggest barriers to moving forward with a knee replacement, is the pain, right? So we're doing a much better job of treating people's pain. It's a multimodal approach. So the way we used to do it, we just throw narcotics at patients, fill them up with narcotics. And it worked, right? So we got lots of side effects. And it was basically like stopping the flow of a river with one dam. And you build a big enough dam and you stop a lot of water. But we're taking a more refined look at it. We're using multiple dams. So we're using Tylenol, gabapentin, anti-inflammatories. Our anesthesiology colleagues are using blocks to numb the leg for the first 24 hours. And once you get 24 hours out, you're way ahead of the game. And we're giving these pain medicines before the surgery, before you even have pain. And it's been a world of difference. The other thing that we can do is preemptively and aggressively treat side effects. The easiest way to take a great surgery and make an unhappy patient is to let them vomit all night the first night after surgery. we give anti-nausea medications, we give stool softeners even before the surgery starts. All right, we want to make a knee replacement last longer. There's a couple ways we can do that. Number one, who has an idea? What's the weakest link in this thing, right? We've got a metal femoral component, a metal tibial component, and that polyethylene bearing in between. The polyethylene, exactly right. The old polys stunk, right? That's a picture of an old poly. You can see how it's all pitted and worn out, right? We've learned a lot over the last 2 decades how to make better polyethylene. And one of the ways is we actually radiate it. And there's these little branches of polyethylene, and they link, and they make a much stronger link, and make a much stronger material. And other companies are putting vitamin E and other antioxidants into the poly, and that seems to make it last longer. So actually, so much so that one of the companies has basically guaranteed their implants. They're saying now that if you have their knee replacement put in, if it needs to be revised at any time for any reason, they will pay for the parts. They will pay for the new parts. And I think that's an interesting thing. No other company's doing it. I'm not really sure exactly what it means because I don't know how many patients are actually paying for their parts, right? It's really the hospital, you know. But maybe that I think the best they can do to put the money where their mouth is. Now, how long does a knee replacement last? I think most people are saying about 15 years. Now think about this for a second. If we know that the knee replacement lasts 15 years, it was a knee replacement that was put in 20 years ago, right? So we believe that with all of these advances, that the knees are going to last longer, but we don't know how long. We'll let you know in maybe 30 or 40 years. Because what they've done is they have these wear simulators, right? They put some mechanical jig, they run the knee through millions of cycles, and they measure the amount of polyethylene wear. And they know what that was in the past, and they know what the clinical lifetime of those old implants were. And with the new implants, they're doing the same thing, and they're measuring the wear. And they're hoping that you can draw a straight line, right? That's going to translate into a much better clinical improvement. That straight line would suggest that current knee replacements are going to last 40 years. All right, the other way that we can make them last better is if we put them in straight. Okay? On the far left is a knee drawn perfectly straight. And the force when you stand on that leg is going right through the center of the knee, and the forces are spreading moving out. On the other two drawings, you're either a little bit of knock-kneed or a little bow-legged, and the force of standing on it goes preferentially through one side or the other, and it wears out faster. Okay? So we're all trying to put the knee in straight. Now, how do we do that? We use these metal cutting guides. Right? You make these bone cuts. It's the only gross picture I got. You put these metal cutting guides on, and you see that little thin thing at the top. It's a capture for your saw, and you run that through, and it creates saw cuts. And then you put the metal implant on that thing, and if that's what defines the alignment. Now, this is the way we currently decide where to put those cutting guides, is with an extramedullary guide, or with a rod going down the middle of the bone from an intermedullary guide. And it works. 20 years ago, this was a revolution. 20 years ago, what people were doing is they'd eyeball it, right? I wasn't trained in that. Right? It's mind-boggling to me, right? So this was a step in the right direction. And a lot of people had great alignment. You had this bell-shaped curve, where the vast majority of people are right in the middle. But you had these tails, where someone's a little bit more knock-kneed or a little bow-legged. And those people, we found out over time that their knee replacements didn't last very long. So we learned that our intuition was you would need to make it straight, and it's true. In fact, it's true. So how do we make this work better? And that's what we're currently doing. This is a plastic cutting jig that's made specifically for the patient's knee. How do we do that? We take a CT scan or an MRI. The computer software builds a model of the knee. About 3 or 4 weeks before the surgery, I do the surgery on your knee in the computer. And then you reverse engineer it, and you get those cutting guides. So that it's actually very interesting. You know, you used to do the surgery, and you make decisions intraoperatively. Right? Now you make the decisions 4 weeks before. And then you take those decisions that you made 4 weeks before, and you remember, and you apply them. Sometimes you have to tweak them a little bit. You can't put your brain on autopilot, but it just front loads the decision-making process, and it makes a better knee replacement. All right, now how do we make it a better feeling total knee replacement? Now this one's the biggest challenge. We haven't gotten this one figured out, but taking what we know from our partial knee replacement experience, I think we're on the right track. What I'm talking about is the status of the cruciate ligaments. This is a drawing. You see those two little white things that crisscross in the center of the knee? Those are the cruciate ligaments. The one in the front is the anterior cruciate ligament, the ACL. That's the one basketball players are always going to be instructed, right? So we like to think that ligaments function like a static rope. They just stop certain motion. But these little nerves inside those ligaments that tell you where your knee is in space without looking at it. And that drastically improves the way the knee feels. Right? It's something you sort of take for granted. The way we do knee replacements now is we make a flat cut all the way across the tibia, and we put this relatively flat tibia right in between, right on top, right? 100% of the time we take the ACL, and some of the time we take the PCL. There are reasons to take it, and there's reasons to keep it. This new one that's currently we're trying to get approved in the United States, it's got a subtle difference, right? That center portion is completely free. It leaves room for the ACL and the PCL to remain, and we believe that this is going to become a significant improvement. It's actually being trialed in Europe, and we're trying to get it to be used here in the United States. All right. Now, I've talked about I mentioned partial knees a couple of times, and I love the partial knee replacement for the right candidate because it's the trifecta. Right out of the box, you get better recovery, better durability, and you get a better feeling knee replacement. But you got to be a right candidate. But who's a right candidate? This is back to that drawing we showed at the beginning. This person with their knee completely affected by arthritis, you do a total knee replacement, they're going to love it. You do a partial knee replacement on that person, they're not going to love it. They're still going to have pain. You do a total knee replacement on this person with only the one compartment, they're going to love it. If you do a partial knee replacement on them, they're going to get the same amount of pain relief, but it's going to take a lot less time to recover. It's going to feel more normal. It's going to last longer. So that's why I like the partial knee for the right patient. So this is what it looks like on an X-ray. Right? So in the pre-op state, you can see that this person's almost got like a shark bite taken out of that one part of their femur, right? But the rest of the knee is perfectly normal. So why throw all that perfectly normal knee in the trash? You just replace the part of the knee that's affected by the pathologic process. So like I said, they're a better recovery. What do I mean by that? A total knee replacement, I tell patients to expect to be back to their normal activities of daily living in 3 months. A partial knee replacement, it's 6 weeks. And that's everybody. They come dancing into the office. You know, anybody who does partial knee replacements has that video on their phone of the 80-year-old grandmother dancing in their office at 6 weeks. It's reproducible. It lasts longer. This particular knee replacement that I do, that I've got pictured here, is the only partial knee replacement on the market that's got 20 to 25-year data. The reason is it's the leader in the market. Most knee orthopedic implants across the board, most of them are all very good. This is one of the few exceptions where there's a difference between the companies. I'm not pushing any company because I'm not even going to say their name, right? But this one has got 20-year data showing 90% survival rates. And it's got a unique design, and that's why. And every other company is trying to copy it and get the same kind of results. And they're having trouble. So this same product is going to benefit from the improved materials, from the better polyethylene. And you can also build the patient-specific cutting guides with this implant too. So maybe we're taking a partial knee replacement that's lasting 20 years, and I don't know how long it's going to. We don't know. We're starting to see with the new generation partial knee replacements that their primary mode of failure is at like 20, 30 years down the line. The other parts of the knee start to fail. Yeah. And they feel better. You can tell from the drawing, we keep all the cruciate ligaments. I had a couple of patients who needed a total on one side and the partial on the other, and every single one of them prefers the partial side. It just feels more like normal. All right, so let's just summarize real quick. We're shooting for better non-operative management, right? We're really starting to understand the role of exercise, not just telling patients they can't do things. We want to talk about what you can do, not only to maintain health, control weight, and to remain active, but also to decrease knee pain. We're going to talk more about biological injections, and we're building a better knee replacement that comes with a better, easier recovery, lasts longer, and feels more.